Йдемо далі по програмці, і я би з великим задоволенням і з великою приємністю я би хотів би запросити нашого доброго колегу Марсина Swierada з медичного клінічного центру м.Забже. Дуже приємно, Марсин, знов тебе тут бачити, що на конференції. В принципі, історія цього курсу починається від співпраці з Марсином. Якби не було підтримки цієї людини, і якби не було підтримки центру м.Забже, то би ми сьогодні не мали би 4-ї конференції. Так що тобі дякуємо.
Дякую вам.
І запрошуємо.
First of all, I would like to say that it's a great honor for me to be here, to be with you, with my friends, and you are my friends for years now, and I think it's a beginning of the great future, especially for you. During few years, when I started to come to you, with the cooperation, you improved a lot. And I hope you are doing the same way like Poland. We are, of course, looking for Germany, for much richer countries than Poland. And we are trying to do our best with this tools, equipment, and money, what we've got in this moment. Of course, we are in the very hard times now, everybody, all over the world. Because of the COVID, we've got the same problems everywhere, all over the world. In the poorest countries, the problems are bigger, of course. In the more rich countries, maybe it's a little bit better, but it's always the same situation. But today I will try to tell about the FFR. This is the new tool. This is a quite old tool, but now it's available here on Ukraine. You've got more and more new equipment. You've got the new catlabs, which are available, which are able to use the FFR. And I will try to say about why we should do this tool, theory about this, hyperemia, and how to make. And most of our patients are with multi-vessel disease. Some of them, they are with, of course, with one vessel disease. And this tool, especially, we are obligated to check which stenosis is significant, which gives ischemia. And very often we are dealing with such problem that we've got the multi-vessel disease, and we refer such patient to the cardiac surgeons. But with the new tool, as a FFR, we can avoid some surgical interventions, and we can pass these patients to the one vessel disease, and then we can stent. Or from one stent, or from one vessel disease, after coronary flow reserve, the stenosis is not significant, then the patient is free with the procedure. The limitations of the angiography, we know it, that from the different points of view, we cannot see the real stenosis. This is quite easy on the A, not so easy on B, but quite difficult to improve on angiography that this is critical stenosis. We can see it on angio like this. Why ischemia is so important? In the papers written by Iskander, the patient with severe ischemia have a higher risk of death. But without ischemia, stenting, without proved ischemia, the outcomes are not good for these patients. About the flow regulation. In normal artery disease, at the rest, we've got the normal blood flow. In exercise, on epicardial artery dilatation, during the exercise, or after administration of dobutamine, or adenosine, or papaverine, the curve of pressure should be like this. But in atherosclerotic arteries, we've got different situation, like this. And then patient develop ischemia and chest pain. Fractional flow reserve. It's calculated from the approximation of the mean pressure behind the stenosis distally to the stenosis. Measure of the pressure is here, PD, and PA in the aorta. And the ratio PD to the PA means the FFR. What we can see in angio, we can see this. But what we cannot see in the angio, this is the microvascularization. And the same situation. There are microcirculation, which is really, really huge in each one myocardium. FFR, a normal vessel, pressure on the beginning of the artery, on the left main or the RCA, should be the same like on the distal part of the vessel. Then FFR ratio is 1. It's a normal situation in the healthy vessel. In an abnormal vessel, we've got such situation that we've got the pressure about, for instance, 100 mercuries on the proximal part, means in the aorta, and on the distal is 70. It means that the ratio is less than 1. In this situation, it will be 0.7. FFR, when the stenosis is significant, when the ratio is 0.8 or less, then the ischemia is proved. This is cut-off value. Of course, as I showed you, the area of myocardial perfusion is a big one, and it depends on the size of the vessel, type and size. How important is the large area of the myocardial perfusion and the artery? For the big artery, we've got the large area of myocardial perfusion, and for smaller arteries, of course, we've got smaller area of myocardial perfusion. How the FFR can be, we can see on such situation. If we've got stenosis, like this, it's a significant one, with a normal, healthy heart muscle, with a scar after myocardial infarction, the FFR could be even normal. How the collaterals influence on the FFR or iFR. If there is no too big collateral circulation, the ratio is like this. If you've got the high, strong collateral circulation, then the ratio could be normal in such situation like before. When the stenosis is significant, when, of course, as I told, when the PD to PA is 0.8 or less. And there is no indication for intervention when the FFR is more than 0.8. How to make the FFR? How looks catheter? Catheter is a wire with a pressure sensor on the 3 centimeters from the tip. The tip can be like J or straight. Then we can make a J, the curve like we like. And we can use the same wire for the angioplasty because it's 0.356 millimeters. And steps of FFR. 0, we should remember about this. 0, normalize drug record. At first, we should equalize, means 0 pressure on the table after connecting of the FFR wire. I will show it. Then we we introduct the wire into the guide catheter, then we should to make normalize. The pressure PD should be like PA. We introduce the catheter through the stenosis, and then we putting the adenosine or papaverine, and then we are recording. First step is connecting. Just after connecting 0, we have when the catheter is outside of the patient. Here we can see the tip, flexible tip, and this is the place where we've got the sensor. The sensor is located. When we are in the aorta, usually we should remember not to put the guiding catheter too deep to the artery. It should be a little bit in aorta. Then we are normalize. Then this, I will show you the curves in a moment. It was before normal. No, it is. Sorry. Can I back? Oh, no. Just after putting the wire in the guiding catheter, we should touch the normalize on the screen, and such two curves, yellow and the red, should be the same before engaging the stenosis. Now we are passing through the stenosis. Please remember about 3 centimeters and the location of the pressure wire sensor, yes. And then we are putting adenosine. How to prepare it? We are using for the RCA 40 micrograms, for the LCA 60 micrograms, and the maximum dosage is 150 for the left artery. How to prepare it? If we've got 6 milligrams of the adenosine, if we are putting it to the 250 saline or 500, then we've got, in this case, we've got 20 micrograms on milliliter, or 10 on this, with this volume. And this is before. If we are giving the adenosine, then we are just after, immediately we are pushing record and waiting for result. And here we have got such case. Then we have two curves, yellow and red, and as we can see, the ratio is 0.81. It is not significant. And now significant one. This is the right coronary artery. And after administration of adenosine, we can see this is significant. Summary. After engagement of the wire into the guiding catheter, we should normalize. The curves should be the same. After engaging placing the wire over the stenosis, primary gradient, then administration of adenosine, measurement, recording, and we are waiting for the same gradient like before, and then we can stop the measurement. And with the same catheter, we can make iFR, which is much more easier, and without adenosine. Of course, we are avoiding the costs and the complications. This is if we are using, somebody found it, that if we can calculate with the same wire another part of this curve, PDPA, then we can be with the same value like FFR. Okay. close relationship between iFR and FFR has been proved. As you can see, the resistance of coronary vessels is very important. After adenosine dosage, resistance in diastole increases because of myocardial compression. It looks like this. And in the FFR, we are calculating the mean resistance, means this. But in the iFR, we are calculating the minimized resting resistance. And it correlates very good with the FFR results. More clinical trials has been done on this, like the fine flare or iFR sweetheart. And it is calculated that the ratio to iFR is 0.89. And 0.89 or less is the significant stenosis, hemodynamically stenosis significant. Guidelines of the revascularization: when evidence of ischemia is not available, FFR or iFR, it means equal, are recommended to assess the hemodynamic prevalence of intermediate grade stenosis. Or FFR-guided PCI should be considered in patients with multivessel disease undergoing PCI. There are two strong recommendations. And the example, with using the same catheter, of course, we can make a pullback. It's very useful to find on which level we can find the stenosis in the vessel. This one is significant. An example of PCI before was iFR before and after PCI. And the pullback in the vessel, long vessel in LAD. Of course, this is significant iFR. And new tool available on the Philips tables and with the special equipment on it, and with the wire, is a co-registration of the angio and iFR together to finding the. You've got such possibilities, for instance, in Lviv in this moment. It's great, but of course it's costly. Summary: patients with stable chest pain, the most important prognostic factor of a given coronary artery stenosis is ability to inducing myocardial ischemia. And we have to prove it. Stenting, non-significant, means non-ischemic, doesn't benefit with stable chest pain, neither in prognostic or symptomatic respect. Doing iFR, FFR, some patients avoid surgery from multivessel disease to, for instance, to one vessel disease. And the questions from the beginning: is this mandatory or the option? Looking for the guidelines, it's mandatory, but for the real life, it's very useful. And especially if we have no proven ischemia before angio. For instance, for the stable patients, of course, from the dobutamine stress or treadmill test. Thank you very much.
Report and
Hello. Окей. Ми почали робити це обстеження FFR, iFR. Ми маємо таку можливість. Зараз набираємо свій власний досвід, але в мене виникають якісь дуже такі питання, тобто особливо негативний FFR-тест. Дуже часто мені здається, що я роблю щось не так, тому що в мене були випадки, і не один, що я робила тест, він був негативний, потім я робила айвус, і я бачила серйозне ураження, дуже довгі, тобто я стентувала, але FFR був негативний. Можливо, я щось можливо, якісь причини цього неправильного виміру, ніби. Тобто, що можна практично порадити, що можна перевірити для того, щоб переконатися, що це дійсно не pomyłkowo negatywny rezultat.
Trzeba też powiedzieć, że u nas było takie powiedzenie, jeśli chcesz zrobić angioplastykę, IWUS. Jeśli nie chcesz, FFR. FFR według naszej opinii w Polsce też patrzymy na koszty. Nie możemy robić sobie za każdym razem u każdego pacjenta. Bardzo, jeżeli chory ma stabilną chorobę wieńcową, niedokrwienie, jeżeli nie udowodnimy tego w debutaminie, czy w teście wysiłkowym, w EKG, to wtedy rzeczywiście u takiego chorego, przy takim multivessel disease, FFR bardzo często pozwala przesunąć tego chorego z kardiochirurgii do angioplastyki. I bardzo często z angioplastyki do takiego optymalnego leczenia medycznego. Trudno jest powiedzieć, bo rzeczywiście bardzo często tak jest. Nie wiem, czy to jest kwestia błędu, ale bywa tak, że jeżeli wykonamy IWUS i zrobimy FFR, no to mamy dwie różne sprzeczne informacje. Zgodnie z guidelinesem powinniśmy wierzyć jednak w FFR. Tym niemniej takie życie codzienne, normalne, jeżeli pacjent mówi, że ma ból, niedokrwienie widzimy, można oczywiście też należy rozważać, gdzie mamy problem. Trzeba pamiętać, że używanie na przykład adenozyny, ampułka też kosztuje niemałe pieniądze. Idealna byłaby infuzja stały wlew, no ale wtedy trzeba wiele takich ampułek. Natomiast jeżeli taką adenozynę użyjemy i zostawimy sobie na później dla drugiego pacjenta, to może się okazać, że dochodzi do inaktywacji leku i w tym momencie hiperemii nie ma. Tak samo, jeżeli nie wykonamy zerowania cewnika, czy też później wykonamy normalizacji ciśnień w aorcie i w naczyniu, albo guiding kateter wejdzie głębiej do naczynia, to są różne drobne jednak błędy, które mogą zaważyć na wyniku. Dlatego trzeba rzeczywiście, musimy ćwiczyć, jak najwięcej robić tych badań i myśmy też dochodzili empirycznie czyli poprzez nasze błędy, niepowodzenia, później oglądamy razem takich pacjentów i decydujemy. Robimy taki właśnie okrągły stół, przy którym rzeczywiście decydujemy, czy rzeczywiście wszystkie te kroki były wykonane dobrze. Staramy się przede wszystkim, aby w czasie procedury udowodnić, czyli nagrać na filmie poszczególne etapy. Tak samo bardzo ważne jest, to jest to, co też czasami wykonaliśmy, ja popełniałem takie błędy, żeby sprawdzić, czy wszystko było dobrze zrobione, na sam koniec ten cewnik FFR dajemy właśnie do aorty i jeszcze raz sprawdzamy, czy PD do PA jest 1. Jeśli nie, znaczy, że popełniliśmy błąd, powinniśmy wykonać jeszcze raz całe badanie. Dziękuję bardzo.